All right, let's go ahead and scrub in. Today, we're dissecting the essential high-yield anatomy of the thyroid gland. Whether you're literally right in the middle of prepping for your first-year MBBS exams, or you're just looking ahead to those future surgical rotations, mastering this vital structure is absolutely crucial. As this incredibly active endocrine organ, the thyroid controls pretty much everything, from your basal metabolic rate to psychosomatic growth and even calcium metabolism. It is literally central to human physiology.
But before we get totally lost in the weeds here, let's start with a classic clinical exam question. This perfectly proves why gross anatomy actually matters in the real world. Imagine a patient comes into your clinic with a lump in their neck. One of the very first things you'll ask them to do is swallow a sip of water. Well, why? Because a true thyroid swelling will actually move up and down as they swallow. Keep that question in the back of your mind because the anatomical answer is going to unlock our understanding of the next fascial layers very shortly.
So here's our roadmap for this explainer. First, anatomy and relations. Second, vascular supply and danger zones. Third, microanatomy and development. Fourth, clinical applications. And finally, we'll wrap up with some revision and MCQs. Okay, let's jump into Section 1, Anatomy, Capsules, and Relations.
So, as the largest endocrine gland in the body, the thyroid is uniquely superficial, which makes it beautifully accessible for a physical exam. The gland itself is H-shaped, tightly clasping the upper part of the trachea, safely sitting opposite the C5 to T1 vertebrae. It's got these two vertical lateral lobes that are connected by a horizontal isthmus right across the midline. And sometimes you'll even find a small pyramidal lobe projecting upwards, which is often tethered to the hyoid bone by a fibromuscular band.
Now pay super close attention here, because examiners absolutely love this. You have to understand the difference between the two capsules investing the gland. The true capsule is formed by the condensation of the gland's own fibrous stroma. The false capsule, on the other hand, is derived from the splitting of the pretracheal fascia. But here's the kicker. The dense venous plexus lies deep to the true capsule. This is literally the exact opposite of the prostate gland, where the venous plexus lies between the true and false capsules. To avoid a massive hemorrhage during a thyroidectomy, a surgeon must remove the gland along with its true capsule. Moving right along to Section 2, Vascular Supply and Danger Zones. The thyroid is one of the most vascular organs in the human body. And honestly, that makes perfect sense, right? It needs to constantly store and release its hormones, T3 and T4, directly into the bloodstream. A great way to remember this is what I call the rule of twos: two main arteries and two crucial nerves. The superior thyroid artery, which branches off the external carotid, travels with the external laryngeal nerve. The inferior thyroid artery, branching from the thyrocervical trunk, travels with the recurrent laryngeal nerve. And here's where it gets really treacherous for surgeons. That recurrent laryngeal nerve unpredictably weaves behind, in front of, or even right between the branches of the inferior thyroid artery. Listen, if you only take one surgical maxim away from this entire explainer, make it this quote: "Near the apex of the gland, the superior thyroid artery and the external laryngeal nerve diverge. The artery is superficial while the nerve is deep. So you ligate the artery as close to the apex as possible to avoid clipping the nerve. Conversely, down near the base of the gland, the inferior thyroid artery and the recurrent laryngeal nerve are intimately close. Therefore, you have to ligate the inferior artery as far away from the gland's base as possible. You mess this up, and there's a very real chance you paralyze your patient's vocal cords. No pressure, right?" All right, Section 3, Microanatomy and Development. Structure dictates function, after all, so let's zoom way into the cellular level. Looking at the microanatomy, we can clearly distinguish two distinct cell populations. First, the cuboidal follicular cells that form the walls of the spherical thyroid follicles. These are basically the workhorses, secreting thyroxine and triiodotyrosine for growth and metabolism. Then, tucked right between the basement membrane and these follicles are the parafollicular cells, or C cells. Now, these actually originate from the neurocrest and secrete calcitonin, which lowers blood calcium levels, acting entirely opposite to the parathyroid hormone. Let's rewind the clock to embryogenesis for a second. The thyroid is actually the very earliest glandular tissue to develop in a human. It starts as an endodermal thickening way up at the base of the tongue around the 3rd week of life. That exact site of origin is marked by the foramen caecum. From there, it forms the thyroglossal duct, which descends down the neck, loops right in front of the hyoid bone, and finally bifurcates at its definitive position in the neck by the end of the 7th week. Which brings us nicely to Section 4, Clinical Applications. Because let's be real, anatomy in a vacuum is kind of useless. We have to look at what happens when things go wrong in the clinic. When the thyroid heavily enlarges, it's clinically known as a goiter. Now, think back to our earlier chat about the false capsule. Because that false capsule is thin posteriorly, benign tumors and massive goiters tend to grow and compress neighboring structures backwards. They'll literally push right into the esophagus, causing major swallowing difficulties, and into the trachea, causing breathing issues. Malignant growths, on the other hand, just relentlessly invade the surrounding tissues. And returning to those embryology steps we just mapped out, if that thyroglossal duct doesn't close and disappear properly, you are absolutely going to see these classic congenital anomalies on your wards. Fluid can pool up to form a subhyoid thyroglossal cyst. If the gland's descent completely arrests early on, you're left with a lingual thyroid stuck at the base of the tongue. Or it can actually descend too far, ending up as a retrosternal ectopic thyroid way down in the superior mediastinum.
Okay, let's wrap this all up with Section 5, Revision and MCQs.
It is time to lock this information in with some active recall. Before we get the questions, take a mental screenshot of these golden facts. Examiners love to rapid-fire test first-year students on these. It's the largest endocrine gland, it's one of the most vascular glands alongside the adrenal medulla, and it is the absolute earliest glandular tissue to develop in the embryo. All right, let's see if you recall our vascular danger zones. Question 1. We know the superior thyroid artery comes from the external carotid, but where exactly does the inferior thyroid artery originate? Got it? It comes right off the thyrocervical trunk, which is a branch of the first part of the subclavian artery. This vital vessel runs up, passes medially behind the carotid sheath, and supplies the lower 2/3 of the lateral lobe and the lower half of the isthmus.
Moving back to our capsules, question 2. What specific fascial layer thickens on the medial surface of the thyroid lobe to tether the gland to the cricoid cartilage?
That would be the pretracheal fascia, which splits to form the false capsule. And hey, this perfectly answers our clinical hook question from the very start of the explainer. Because the pretracheal fascia anchors the thyroid to the laryngeal cartilages, and your larynx naturally moves up when you swallow, the thyroid gland gets pulled right along with it. Question 3. Surgically speaking, where exactly does the thyroid venous plexus lie? Think back to our direct comparison with the prostate gland to avoid a life-threatening hemorrhage here. It lies deep to the true capsule. Because of this, surgeons must always remove the gland along with this true capsule to prevent severe bleeding. Just remember, the prostate is the exact opposite. Its plexus is between the capsules, so the true capsule is left behind during a prostatectomy. Okay, let's finish up the whole shebang with 2 final rapid-fire questions covering embryology and nerve innervation. Question 4. What is the most common form of an incompletely descended thyroid? And question 5. If a patient has weak phonation after a thyroidectomy, which specific nerve was likely damaged? The answers are the lingual thyroid, which gets stuck right up at the base of the tongue, and the external laryngeal nerve. Damage to that external laryngeal nerve paralyzes the cricothyroid muscle, leading to a loss of tension on the vocal cords, hence the weak phonation. That proves once again that a rock-solid mastery of foundational anatomy is the absolute bedrock of brilliant clinical outcomes. But, if the subtle anatomy of the neck can dictate the success of a simple swallow or a complex, high-stakes surgery, what other unpredictable microscopic anomalies are hiding in the fascial spaces of the human body, just waiting to catch an unprepared surgeon off guard? Makes you wonder, doesn't it?